cheaper version of flow diverters. Flow diverters are 10 to 12 lakhs plus procedure cost. It works 15-16 lakhs. Whereas bypass with flow alteration will be very cheap at one-third the cost. You can do a bypass with trap ligation. I'll give examples from the cases we have done in the past 20 years. We've done almost 1,000 cases. This includes my experience at NIMS as well as KIMS. When you decide to do aneurysm, there's a basic step that when one dissects the vessel, avoid dissecting on the side where the perforators or branches are coming out. As you can see here, in ICA, the choroidal artery in the PCOM comes to the posterior surface. The perforators from the A1 or the M1 comes to the superior surface. So whenever start dissecting the vessel, do the green line, do on the opposite side of the vessels so that you do not damage any perforators. So post-op vasospasm of the perforators are less, post-op complications are less. Always preserve the parent vessel when this is an aneurysm of the PCOM. So in a PCOM, one can see here, I'm trying to preserve the choroidal artery, trying to preserve the PCOM posterior communicating artery as well as the parent vessel of the ICA. So whenever one does an aneurysm, and these are the aneurysms which are projecting which our endovascular people said that they are not good for coiling. And because the PCOM was coming at the neck, they thought that the PCOM probably they cannot spare it, so we went for surgery. So preserve the parent vessel, preserve the surrounding perforators whenever one operates an aneurysm. Many times when you place one clip, morning Dr. Amir Basa presented on different dyes that you can use ICG, you can use fluorescent. After putting the clip, check that the parent patency is there, the aneurysm is not filling. But that is not enough, because at the end of clipping also, even if in a fluorescent dye the aneurysm is not seen, it is not foolproof. One has to always puncture the vessel, the dome, and see that there is no flow. That is only 100%, that's the gold standard. So many times when we puncture, we still see, you can see here after putting the clip, though the clip is beyond the neck, the aneurysm is still filling. So the occluding, in this case, the occluding pressure of the clip probably is not adequate for occluding the aneurysm. Then one has to use multiple clips. So use more than, don't hesitate, just for the cost, don't hesitate to put a second clip. So in this case, we had to use 2 clips. Second clip you apply so that the aneurysm is occluded, and then we punctured and checked that there is no leak from the dome of the aneurysm. And especially when we keep on reusing the clips keep on rotating to other hospitals. So we do not know the occluding pressure also would have changed. So always check, puncture it if there is no bleed, and use a second clip whenever it is required. Let me give an example of clip application to reconstruct parent vessel where the neck is very wide, like this case. This we did an ICG of, this is a MCA vessel. You can see here the wide neck, of the MCA bifurcation, wide neck with the aneurysm, the MCA. And so here we placed again 2 clips, one on either side, to reconstruct the parent vessel. Now this is not easy with coiling because it's a wide neck. One can use a web device, but that web device is 15 lakhs. So putting 2 clips is very cheap, which is very cost effective, which can be done at Warangal, Karimnagar, Hanamkonda, everywhere. So reconstructing a parent vessel is another technique which you use for wide-necked aneurysms. Now what do you do for giant aneurysms like this? There's a very irregular vessel, PCOM coming out from the wide neck. Endovascular people said they cannot coil it fully. They said they can do partial coiling of only fundus. We didn't want a partial surgery. So we said we opted for surgery, and this patient underwent clinoid drilling. Dr. Narasimha morning presented the techniques of clinoid drilling, intra and extradural. So we do a combination of intra and extradural drilling where we identify the optic nerve, then identify the ICA, and then reconstruct the ICA with multiple clips. And so that we put fenestrated clips so that if the choroidal artery in the PCOM can be saved, the patency of the PCOM and choroidal can be saved. So this is what clinoid drilling is required whenever there is a giant paraclinoid aneurysm, and all the vessels can be saved by putting straight fenestrated clips. But if the vessels are not coming out, you can put a rectangular fenestrated clip so that you can you can do it with only 2 or 3 clips. So depending on the anatomy, one has to use different types of clips and plan how clipping has to be done. And then at the end of clipping, you can do an ICG. We saw that after ICG, there is a small part of the fundus is still filling with fluorescent angiography. So we put another clip and confirm that there is no filling of the fundus. So these are the different types of clipping technique we use. It's called tandem clipping or counterfacing clipping. One can do multiple straight clips to reconstruct the dome, or retrograde clipping. If you have abnormal vessels, then you have to preserve the parent vessels. So different types of clipping technique. One has to be an artist thinking how to preserve the parent vessel. So some amount of both right and left brain is required to do a proper surgery. It's not only just a simple technical job of putting a carpentry job of putting a clip, because one has to preserve perforator, preserve the parent vessel, and use your artistic mind to create the normal physiology of the normal vessels like this. So you should have multiple type of clip and plan it properly with a 3D orientation, that how many clips you will place and how differently it has to be placed, so that the normal anatomy is recreated. And these things are not easy with coiling, because they work with a 3D picture, just a AP and lateral, AP lateral, and this under surgery you do with a direct under vision of 3D orientation, you get a better orientation of recreating the normal physiology. The third technique is clipping with a contralateral craniotomy. This patient came with multiple aneurysm. You can see here, there is a bleed on the left side. There is an MCA bifurcation aneurysm, but on the right side injection, there was a right paraclinoid aneurysm on the right side, which is pointing medially. And so endovascular people said if they do this coiling, they'll put it's a wide neck, they cannot do. So we did clipping of this, but then we thought we can probably do the clipping of the opposite side in the same surgery. So we first clipped the MCA aneurysm, and then to the same incision of the left craniotomy, we did optic canal decompression of the opposite optic nerve. This is the opposite optic nerve. We're doing reflecting the dura, and drill the optic nerve and mobilize optic nerve. Now we can see the aneurysm here, the fundus of the aneurysm seen here. So we identify the lower part of the neck, upper part of the neck, and so drill further to mobilize the optic nerve. And then clip the aneurysm. You can see here the fundus. After drilling, you can see the fundus as well as the lower and upper part of the neck. And this we have published in one of the textbooks 2 years ago. So for the patient point of view, we avoided one more craniotomy. We did not go for the opposite side. With one surgery, we could do multiple clippings. The other technique what to do is excision of aneurysm with end-to-end anastomosis. Like this 11-year-old boy came 2 years ago and with a bleed, and this was the angiogram. It showed a fusiform aneurysm. You can see here fusiform aneurysm. So our plan was to excise the aneurysm and do anastomosis from the pericallosal to the callosomarginal, end to side anastomosis, because when you excise we cannot, so this vessel we have to anastomose to the pericallosal artery. But fortunately, when we operated, these are uncoilable aneurysms. This also we published in one of the technical standards of textbook as a chapter of all the uncoilable aneurysms, clipping for uncoilable aneurysms. So we did an anti-hemispheric approach, identify the aneurysm, and we excised the aneurysm. You can see here, this is the fundus. We excised the aneurysm, and fortunately we could mobilize both the vessels and do an end-to-end anastomosis of the ACA. ACS, they can tolerate temporary clipping till 45 minutes. So we need not worry about having infarct and all those. So we excised the aneurysm and did end-to-end anastomosis, which again can be done in any district place, in Karimnagar also and Warangal also. We don't have to have a hype on the cath lab or have get flow diverters and all those. And many times flow diverters are not available for the small vessels also. And this patient came or follow-up came in February last month for follow-up, and this is a post-op CT angio showing patency of the anastomosis what you have done. And this patient is now studying in class 10th. Sorry, class 8th. The next technique what I saw is bypass with flow alteration. Now what is flow alteration? When you have a giant aneurysm, the ICA, now all of you know that they advise a flow diverter. They place a stent from to the wide neck to as a flow diverter, and that is around 12 lakhs, and then you have to give double antiplatelets. Here what we do is a patient who cannot afford, and whenever the aneurysm is very long, then they do not have adequate length of flow diverters also available. You don't have very long flow diverters available. Then they say that they cannot do flow diversion. So here we do called flow alteration. Flow alteration is we just ligate the proximal ligation and do a bypass. When you do a bypass, the pressure inside the aneurysm reduces. So because of that, the aneurysm over a period of time it shrinks in size. So that is called surgical flow alteration. It can be done in large MCA bifurcation, large ICA bifurcation, and large cavernous aneurysms also. So this is